I'm not going to do any knee tricks today. I'm just going to use the one slide there. All right, so we'll review the anatomy of the knee. So what are the basic structures that are involved when we're talking about the knee? Well, which bones specifically? Yeah. So the primary thing is going to be the femur and the tibia, and then also you have the patella, which is part of the knee joint. And then typically you're going to include the fibula, the superior or proximal tib-fib joint. And then you also have another one on the other end. You have the distal joint between the tib and the fib. And fibula just kind of moves. There's not a whole lot of movement going on, but there can be some issues with that. Then we'll talk about the other end nerve tissues. So what's the other end nerve tissues besides bone? Yeah, okay, so we'll have some ligaments in the knee, and then what else? Yeah, cartilage or meniscus. So the meniscus is a separate cartilage, fibrocartilage, and then also you have the actual cartilage surface of the knee. And so we'll talk about the actual articulations in the knee. So then what would be the contractile tissues that are involved with the knee? Yeah, so basically how many, you've got the knee extensors, knee flexors, okay? So what motions occur at the knee? What kind of joint is the knee? The hinge joint, right? So typically what we call a modified hinge joint. And what kind of motion occurs at the knee joint? Flexion. Flexion extension. Anything else? Yeah. So to rotate the knee, what position does the knee have to be in? Can you rotate your knee when it's like this? No. Can you do it when it's like this? Yeah. So there's going to be a little bit of internal external rotation in the knee when the knee is flexed. And is there very much stuff neurologically or nerve structures that are clinically significant in the knee? Not really that much. The only thing is that you have the common peroneal nerve comes around right here around the head of the fibula before it divides into the superficial and deep. So sometimes if you have an injury to the head of the fibula, you can affect the nerves in that area. And then, let's see, that's pretty much it. Vascular, again, there's not going to be so much going on in the knee as far as vascular tissues. All right? Most of the time when the knee is functioning, it's going to function under gravity. So there's going to be a load on it, which is compression like this. Okay? So it's axial compression. When you're standing, walking, so there's pressure on the knee. And it's basically these two long lever arms. Basically, again, the knee joint's primarily between the femur and the tibia. Okay? But the knee has to do two different things. Okay? There has to be stability, so when you can stand, you don't want to flop down over a bag of bones, right? Your knee has to be stable, but it also has to have mobility. Okay? So the knee joint is not as, by the structure of it, is not quite as stable as something like the hip joint. Because the hip joint, they have a deep ball and socket type of a joint, so the femur is locked in there pretty well. On the tibia and the femur is the one that actually has more like a condyle type surface, has a curved surface on here, on these condyles. Okay? On the tibia, they can be referred to as tibial condyles, but a lot of times it's called a tibial plateau. Because if you're looking at the top of the tibia, for the most part it's flat. You do have these two little intercondylar eminences, which is where the ligaments are going to attach. We'll get more into that later. But for the most part, like you can see on here, this is pretty much a flat surface here. So that's the tibial plateau, and then you have the femoral condyles. And what's going to add to some of that stability to give that tibial plateau a little bit more of a dip to it, or more of a socket? Yeah, meniscus. So there, it's like a velodrome, you know, where they ride the bikes around in the circle and they have the bank curve like that. So it makes it more into a bowl. So that femoral condyle fits into a little bit of a bowl. So it gives it a little bit more stability. It's like when we had in the shoulder, you had the labrum that went across around the joint to add a little bit more of a lift. So the meniscus is a piece of cartilage that's going to give it more of a bank like that, so that the condyle of the femur sits into it, gives it a little bit more stability. So when we're talking about biomechanics, we talk about static positions and you talk about dynamic conditions. So the things that are going to give stability to the knee when it's static is going to be the ligaments and the meniscus. Okay, so when I'm standing here on my knee like this without moving, it's going to be held stable by the ligaments and the structure of the joint like the meniscus. Okay? But then when you're talking about movement, then that's when you're going to have stability that brings the muscles into play. Okay, so dynamic and kinetic things are going to involve muscles more. So again, the bones of the knee are going to be, the primary ones are going to be the femur and the tibia, and you also add the patella into it, and then you have a little bit going on with the fibula. So the patella is really almost more part of a contractile tissue because it's inside of the tendon. Okay, it's a sesamoid bone. Sesamoid bone meaning that the bone that's inside of the tendon, and what it does is it gives it more mechanical leverage at the knee joint. I mean, the knee can extend a lot better, and this muscle group and tendon works better when it has this bone in here to act like more of a fulcrum. So you're going to get better motion there, better power in the extension of the knee with the patella there versus if it was just tendon. Okay? And the patella primarily is going to be in contact with the femur, not really the tibia. And depending on how the knee, what position the knee is in, it's going to be in contact with different portions of the femur. Okay, so basically you have this intercondylar groove where the patella slides in through that. So as the farther you flex the knee, the farther down on the surface of the femur that the patella is going to be in contact with. Okay. And the patella is where the thickest surface of cartilage is that you're going to find in the body is going to be on the back of the patella. So again, the primary joint of the knee is between the femur and the tibia. So we're going to talk about the different structures that are in there. Right? Again, the femoral condyles are these curved surfaces here that are covered with cartilage. So the inner portion of it is going to be more smooth, whereas the outer side here, it's not an articular surface, so that's going to be more rougher part of the bone. And then you can have these epicondyles here. And then, again, on the tibia, underneath here where these cruciate ligaments attach, there's a little point, two little tips of bone that stick up, and those are the intercondylar eminences. Those are attachment points for the cruciate ligaments.
Is it on the femur or on the tibia?
Tibia. And then you have the joint capsule. And I don't really have a picture of this in the notes, but I'll draw it up on the note. So this is looking at the tibia, looking down on it here. Here's the anterior portion. Okay, so, all right, so let's talk about the joint capsule. Okay. And then you have ligaments. What are the ligaments in the middle of the knee? Cruciates, yeah. Okay. So those are going to be crossed like this. And then you're going to have the collaterals. You have the medial collateral and the lateral collateral.